Magnetic resonance imaging, or MRI shortly, is a medical imaging technique used in radiology to form pictures to the anatomy and the physiological processes of the body. MRI scanners use strong magnetic fields, magnetic field gradients, and radio waves that generate images of the organ in the body. MRI does not involve X-rays or the use of ionizing radiation, which distinguishes it from CT and PET scans. So, we can do magnetic resonance imaging even the pregnant woman. But you must understand, if some patient have some metal or like a hip prosthesis or prosthesis of the elbow, he cannot do magnetic resonance imaging, because you must know this is magnetic field. So if this patient with metal in his body go through the magnetic resonance imaging, it can explode. Metal prothese can burst some parts of the body of the patient, and it hurts a lot. So it's prohibited to use magnetic resonance imaging for the patient with metal in the body. And a couple of different radiology methods. I give you a couple of seconds to understand what do you see on this picture and how it's method named. Okay, for those who look on this picture precisely, you can see the tube with the residual contrast material. So this method called bronchography. It allows us to see the bronchus tree, but now it's not used frequently because it's too irritating of the lung, to the bronchus. So many allergic reactions we have when we use this method. So it's now most of the history. And how this radiology method named? Look precisely what do you see on this picture. Okay, it must be enough if you know what this method named. It's pulmonangiography. We see dense structures on this picture. It's vessels of the lung. Here we see a normal X-ray image of the lungs, of the chest. We see the backbone, spinous processes, transverse processes of the vertebra. We have see the ribs, clavicle, humerus. We see the scapula, right and left. We can see the heart and the aortic bundle. We see the trachea, carina of trachea or bifurcation of the trachea. This is the part where the trachea divides to the right and left bronchus. You can see on this picture that right bronchus is more direct than left bronchus. Left bronchuses go by the angle and right bronchus go strictly forward. Why is this important? It's important because right bronchus is most common feature of the aspiration of the foreign body. If somebody coughing and or try to eat some particle, and this particle go to the through the trachea to the lungs, you can search it in the right bronchus. So we see some part of the abdomen below the dome of the diaphragm. This is the air in the stomach. All black what we see here, it is air in the lungs. We see these thin structures, it's vessels of the lungs, it's hilum of the lungs. We have two pockets, if we wanna call them like this, Costophrenic and Cardiophrenic. We must look here for the pleural effusion. So we go next. Lobes and fissures, right lung. This cutout of a lateral chest X-ray shows the position of the three lobes of the right lung rollover image, separated by the horizontal and oblique or major fissures. So we have upper lobe divided by horizontal fissure, middle lobe, and lower lobe. You must remember 2 lobes on the left and 3 lobes on the right. This is left lung, upper lobe and lower lobe, divided by 1 oblique fissure. Horizontal fissure. The horizontal fissure separates the right upper lobe from the right middle lobe. It may be seen on a normal chest X-ray as a thin line running roughly horizontally from the edge of the lung toward the right hilum. It's very difficult to see here horizontal fissure, but try to find it. Okay, it's very difficult, I understand, so I write down where it's placed. This is it. Try to compare these two pictures. Go further. Oblique fissures. The oblique major fissures overlie each other on the lateral view and are not always seen entirely. If seen at all, the lower and usually seen most clearly dotted lines, predicted position. The horizontal fissure is not seen at all on this lateral image, white dotted line, predicted position. Try to compare these two films. Accessory fissures. The azygos fissure is the most common accessory fissure visible on a chest X-ray, 1 to 2% of individuals. In the most people, the azygos vein passes horizontally along the right side of the mediastinum. In those with an azygos fissure, a small section of the right upper lobe, an azygos lobe, develops medial to the vein, which is pushed away from the mediastinum. The azygos vein appears to pass through the lung and is surrounded by both parietal and visceral pleura. The azygos fissure therefore consists of 4 layers of pleura, 2 parietal layers and 2 visceral layers. The appearance resembles a tadpole. The head is the azygos vein and the tail is the azygos fissure. Note that the azygos lobe is not a separate lobe, is a part of the right upper lobe. So here we see azygos vein and azygos fissure, and this part on this film called azygos lobe. Assessing the fissures. Occasionally lung disease is limited in extent by a fissure. This can help locate a disease process, more specifically to a lobe. For most cases, this degree of accuracy is not clinically important unless further action such as biopsy or surgery is required. in which case other imaging such as CT would probably be performed. In most cases, it is still best to refer to the location of lung abnormalities seen on a chest X-ray in terms of lung zones rather than lobes. Diaphragm. The right hemidiaphragm is slightly higher than the left. The liver is located inferior to the right hemidiaphragm. The stomach and spleen are located inferior to the left hemidiaphragm. The hemidiaphragm contours do not demarcate the lowest part of the lungs. The diaphragm separates the lungs from the abdominal organs. The abdominal organs are more dense, whiter than the air-filled lungs, blacker. Each hemidiaphragm should appear as a smooth domed contour. The right hemidiaphragm is usually a little higher than the left. The liver is located immediately inferior to the right hemidiaphragm. The stomach and spleen are located immediately inferior to the left hemidiaphragm. It is important to be aware that the lower portion of the lungs, which occupy the posterior costophrenic recesses, extend below the level of the contours of the hemidiaphragms. The stomach bubble, you remember the stomach bubble? It's air, forms a window through which the part of the lung is visible on the left. Diaphragm. Here you see dotted lines. It's right hemidiaphragm and left hemidiaphragm. Air in the stomach, liver and spleen. You can see the shadows. And you can see by the asterisks as cardiophrenic angles. And here we have Costophrenic angles. Hemidiaphragms lateral view. Lateral X-ray shows the right hemidiaphragm extending from posterior to anterior. The left hemidiaphragm becomes indistinct at the lower edge of the heart, and the stomach bubble may be seen below it. Inferior displacement of the diaphragm is a sign of a lung hyperexpansion. A raised position of a single hemidiaphragm may indicate phrenic nerve pulse. So here we see the levels of the right and left hemidiaphragm. Costophrenic recesses and angles. The costophrenic angles are limited views of the costophrenic recesses. On a frontal view, the costophrenic angles should be sharp. The costophrenic angles are formed by the positions at which the chest wall and diaphragm meet. The costophrenic recesses contains the lower edges of the lungs, which contract the diaphragm. Costophrenic blunting is often due to the presence of a pleural effusion, but it can also be related to other pleural diseases or lung disease. Lung hyperexpansion can also lead to blunting of the costophrenic angles. This is because the dooms of the diaphragm are pushed downwards, and so the angle becomes rounded. Costophrenic recesses and angles. Here we saw costophrenic recesses and costophrenic angle. Another pictures, but from the another point of view. Heart sizes and contours. Heart size is not assessed by an absolute measurement, but rather is measured in relation to the total thoracic width, the cardiothoracic ratio. Cardiothoracic ratio, cardiac width to the thoracic width. The cardiac-thoracic ratio is frequently expressed as a percentage. ACTR is greater than 1 to 2 or 50% is considered abnormal. Accurate assessment of heart size assumes the projection is posterior-anterior, and the cardiac size is not exaggerated by factors such as patient rotation. So this is the normal cardiothoracic rate. It's below the 50%. Normal heart on the film. This is left ventricle and right atrium. Mediastinal contours. The heart is located in the middle mediastinum. Other visible structures of the mediastinum should also be checked when viewing a chest X-ray. These include the aortic knuckle, descending aorta, aortopulmonary window, and the right paratracheal stripe. Some structures of the mediastinum are not visible on a chest X-ray, for example the esophagus, posterior mediastinum, great vessels, superior mediastinum, and thymus, anterior mediastinum. Mediastinum. Here we see aortic knuckle, left main bronchus, dark structure, and descending aorta. Normal aortopulmonary window. The aortopulmonary window is located between the aortic knuckle and the left pulmonary artery. It is a space where abnormal enlargement of mediastinal lymph nodes can be seen on a chest X-ray. Here we see ascending aorta, aortic knuckle, aortic pulmonary window, and descending aorta, and this is left pulmonary artery. Normal right paratracheal stripe. From the level of the clavicles to the azygous vein, the right edge of the trachea is seen as a thin white line or stripe. This stripe is created by airflow of low density, like a line, either side of the comparatively dense whiter tracheal wall. Thickening of the paratracheal stripe, normally less than 3 mm, may represent pathology such as paratracheal mass or enlarged lymph nodes. The left side of the trachea is not so well defined because the position of the aortic arch are great vessels. Here we see the azygous vein or the right paratracheal stripe. Soft tissue. On every chest X-ray, check the soft tissue, especially around the neck, the thoracic wall, and the breasts. If a patient has very thick soft tissue, due to the obesity, underlying structures such as the lung markings may be obscured. Large breasts may obscure the costophrenic angles, giving the impression of the presence of pleural effusions. Black within soft tissue may represent gas. Breast. Lung markings of the lower zones, white boxes appear denser on the left than on the right. This is due to breast asymmetry, which is very common. It should not be assumed that the patient has had a mastectomy unless this is known from the history. Don't mistake breast asymmetry for underlying lung disease. Here we see shadows of the breast. They are asymmetrical on this picture, and this is normal. You must remember it. Nipple shadows. If there is any doubt that a nipple shadow could be a lung nodule, then a repeat chest X-ray should be performed. Metallic nipple makers are used to indicate the position of the nipples. On this picture, we have two nipple shadows. I highlight it to you. Soft tissue fat. This close-up demonstrates a normal fat plane between layers of muscle. Fat is less dense than muscle and so appears blacker. Note that the edge of fat is smooth. Irregular areas of black within the soft tissues may represent air tracking in the subcutaneous layers, surgical emphysema. So, here on this picture we see the fat. The X-ray appearances of soft tissues of the chest can be misleading, as well as hiding genuine pathology. Normal soft tissues may mimic disease. If you are in doubt, the first thing to do is to re-examine the patient. If you are still uncertain about the X-ray appearances, then discuss the image with a radiologist. Bones. Bones are the densest structures visible on a normal chest X-ray. Despite this, it's too easy to overlook important abnormalities of the bones, which may be very subtle. The bones visible on a chest X-ray include the clavicles, the ribs, the scapula, the spine, the proximal humerus, upper arms. The sternum is also included on a frontal view, but it overlies other midline structures and so is obscured. The bones are used as useful marks of chest radiograph quality. They are used to assess patient rotation, adequacy of inspiration, and X-ray penetration. The bones are helpful landmarks in assessing chest X-ray image quality. Clavicles, spinous processes, ribs. The spinous processes of the vertebra, posterior structures, and the middle ends of the clavicles, anterior structures are landmarks to assess rotation. We see clavicles on the equal level, so we have no rotation. It's a good anterior-posterior film. By number 1 we saw the clavicle, number 2 acromioclavicular joint, number 3 acromion process of the scapula, 4 body of the scapula, 5 glenoid fossa of scapula, 6 head of left humerus, 8 coracoid process of scapula, and 7 coracoid process of scapula. Clavicle and ribs. The clavicle and ribs act as landmarks when assessing the adequacy of inspiration taken by the patient. The anterior end of approximately 5 to 7 ribs should be visible above the point at which the mid-clavicular line intersects the diaphragm. Less than 5 ribs indicates incomplete inspiration. More than 7 ribs suggest lung hyperexpansion. On this normal X-ray, the anterior end of the 7th rib asterisk intersects the diaphragm at the mid-clavicular line. The subcostal grooves are visible on the underside of the ribs, red highlights. These grooves contain the subcostal nerves and vessels that accompany each rib. Note: to avoid damaging the subcostal nerves and or vessels, the superior edge of the rib is used as a landmark during procedures such as chest pain insertion. The spine can be seen through the heart, indicating adequate X-ray penetration. Clavicle and ribs. So we here see the clavicle and ribs. This is background. Assessing the bones. Bones are useful for the initial assessment of chest X-ray image quality and offer useful information regarding rotation, inspiration, and penetration. Acute rib fractures are often invisible, therefore chest X-rays are not helpful and there is clinical suspicion of a rib injury unless a complication such as pneumothorax is suspected. Occasionally you will see an important abnormality of the bones on chest X-ray, such as bone metastasis. Bone abnormalities may be very subtle, so always look carefully at all the bones when viewing a chest X-ray. We have several types of abnormalities. What we can see on the chest X-ray. We can see nodule, cavities, pleural abnormalities, diffuse shadowing, reticular linear pattern, nodular pattern, cystic, ground glass opacities, and consolidation. First of all, we see nodule. I give you 10 seconds to understand where the nodule placed. So time is up. Here our nodule. This is a very difficult sample, I understand, but you must be always ready that the shadow of the heart or another structure can hide from us the different structure what we didn't expect to see. This is nodule, obscured by the heart shadow. This is the same patient, but on the CT scan we can see this tumor with metastasis in the lung nodules. Cavities. I give you a few seconds to understand where the cavity on this film is placed. Who look precisely can see the picture of the tumor with cavity. This is the cavity, more darker. Now we talk about pleural abnormalities. We can see pneumothorax, hydrothorax, Pneumohydrothorax, Haemothorax, and thickening of the pleura. Pneumothorax, thorax. We can see that upper part of the left lung is not normal lung picture. Because when we see normal lung picture, we can see some vessels. It's irregular structure, and here we didn't see any vessels. Haemothorax. It can be a pleural effusion, but here in this picture we see broken ribs, so we can expect Haemothorax, not pleural effusion. Pneumohydrothorax. We can see on this picture Pneumothorax and Hydrothorax. Why do we expect the Pneumohydrothorax? In this picture we see that the level of the liquid in the pleural cavity convex, and here we see the horizontal line. It's because air in the pleural cavity is give pressure on this liquid, and we have here the horizontal line, and in the upper part of the pleural cavity we didn't see the picture of the lung vessels, like here. Pleural effusion. This is convex line in this pleural cavity called the meniscus sign. Diffuse shadowing. We have shadow, it diffused, we have reduced level of pleural vessels, so it's diffuse shadowing. And here we have reticular liner pattern on the lung picture. You can see the right dome of the hemidiaphragm is upper than the left. Maybe this patient have a cirrhosis of the liver. Another cavity, it's cyst in the lung. This is a picture of the ground glass opacity. You can see the difference in the dance of the picture, and this is very important now, because on the early evidence of the SARS-CoV-19, it's ground glass opacities on the CT scan of the lungs. Here we saw the consolidation on the X-ray, and here we have the algorithm how you read the X-ray or chest X-ray. First, write down the data of the patient, name, gender, age, etc. Second, characteristic of the X-ray: rigidity, contrast, sharpness, and artifact. When we saw on the picture, how we can say about sharpness. If we have saw the blur, we didn't see normal clavicle or ribs or backbone, it's not sharp enough. About rigidity, on normal chest X-ray, we must see 3 to 4 vertebrae with spinous processes. If we didn't see this, our rigidity cannot allow us to see normal lung picture. We cannot assess lung picture on this X-ray. Artifacts. Sometimes we can see some artifacts. It means this is some detail which not allowed to the picture. Maybe sometimes it's metal in the nipples or in the bones. This structure cannot help us to lead to the diagnosis. So we must re-examine our patient. Projection, anteroposterior side, and rotation. In normal chest X-ray we need not rotation. As I see below, we can assess the rotation by the level of the clavicle. If the clavicle on the equal level, it's no rotation on this picture. Shape of the chest: barrel, pigeon, funnel, and kyphoscoliosis. The main regions where a chest X-ray may identify problems may be summarized as ABCDEF by their first letters. First, A. Airways, including hilar adenopathy or enlargement. B. Breast shadows. Sometimes you can see breast tumor as a shadow. B. Bones. Example criteria: rib fractures and lytic bone lesions. C. Cardiac silhouette detecting cardiac enlargement. C. Costophrenic angles includes pleural effusions. D. Diaphragm. Example criteria: evidence of free air indicative of perforation of an abnormal fissures. E. Edges. Example criteria: epices for fibrosis, pneumothorax, pleural, thickening of plaques. E. Extrathoracic tissues. F. Fields, lung parenchyma, being evidence of alveolar flooding. F. Failure. Example criteria: alveolar airspace disease with prominent vascularity, with or without pleural effusions. After assessing of the chest X-ray, you must write down your answer to the questions. This is example. First, this is patient name Lisa M, female, 29 years old. Characteristics of the X-ray: it's normal rigidity, normal contrast, it's sharp enough, and we have no artifacts on this X-ray. 3. Projection, anterior-posterior. Clavicle on the same level, so we have no rotation. Shape of the chest, normal. Airways, normal, not enlarged. Breast shadows, without pathology. Bones, not injured. Cardiothoracic rate, is normal because it's less than 50%. Costophrenic angles, clear. We don't see evidence of effusion on this chest X-ray. Diaphragm, normal level, no evidence of free air. Edges, normal or thin. Extrathoracic tissues, no evidence of subcutaneous emphysema or tumors. Diffuse, 1 parenchyma, normal opacity. And now put your video on the pause and try to write down answers. What do you see on these pictures? And on these pictures. That brings me to the end of the presentation. Thank you for your attention. I hope you know more about chest X-ray after this video. Sorry for my horrible accent, for my horrible English, but I think this video can be usable for you. So thanks a lot.